Hello everyone and welcome to my channel. We have already discussed the CBS examination, that is cardiovascular examination for the medicine talks. In this video we will learn the respiratory examination. So all the basic techniques are discussed in the first video, that what are the steps that we have to do in the examination. Now we will discuss it specifically for the respiratory system. First of all, introduce yourself that I am Dr. Desh and I will be examining you. Then ask the patient name, that what is his name and his age. Then explain the procedure, that I will examine you and I will expose you and there will be no problem. But if you have any problem, you can tell me. Then take the consent of the patient, that do you have any problem? The patient will says no. Then expose the patient and start your examination. So first of all, you have to do the general inspection, that is inspect from the end of the bed. Then you have to inspect that there is any treatment around the bed, that is if there is cannula present or if any catheters are present. So you have to inspect the patient for that. Then inspect the patient for general condition, that is if there is any shortness of breath present, if there is any cough or wheeze present, if stridor is present, or if cachexy, that is muscle loss, is present. So all you have to find these things with the general inspection. So what you find on a general inspection? First of all, you notice that if there is any treatments present, that is catheters or cannulas or IV drips, etc. Then you will see that if the patient is cynosed or he is normal, then you will see that if there is any shortness of breath present, any types of stridor present or wheeze present, or the cough is present, then you will see the cachexy, that is if there is any muscle loss in the patient. This was the general inspection. Then the next step will be the inspection of the hands. Okay, you will inspect the hands to note any peripheral cyanosis in the hands which mark the respiratory disorders. Then bruising or thin skin, that which is due to the long term of the steroid use. You will see that if there is any bruises or thin skin present in the patient, if it is present, then it means that the patient is using steroids from long time. Then you will look for the tar staining, that is you will look for the fingers of the patient. If there is any staining present, then this shows us that the patient is smoker. Then we will look for the finger clubbing, that is Shamrod's video test. Okay, so if there is any clubbing or if the Shamrod's window is lost, then this mark congenital heart diseases. So you will look the patient for it, then assess and compare the temperature of both hands. Then assess for fine tremors, that is beta agonist uses salbutamol. This lead to fine tremors, so you will look for this. Then assess for sterexis, that is CO2 retention. Then palpate the radial pulse, this is assess the rate. And then assess the respiratory rate, which is normal. Normal is 12 to 20 breaths per minute. Okay, so you have inspect the patient hands, and what you will find, you will inspect for the any peripheral cyanosis. You will check for the bruising or thin skin. Then you will check for the tar staining, the finger clubbing. Then you will assess and compare the temperature. Then you will assess for the fine tremors. You will assess for the sterexis, that is CO2 retention. Then you will palpate the radial pulse and you will assess the respiratory rate. All you have to do this on the inspection of hands. Okay, after this you have to assess the jugular venous pressure with patient at 45-degree angle, and it is located between the two heads of the sternocleidomastoid. This is the patient and this is the location where it is present, the jugular venous pulse, JVP. You will find the JVP in the patient at the angle of 45 degree. You have to put the patient in 45-degree angle and then you will check for the JVP. If it is raised, then it marks the common lung disorder, that is cor pulmonale. Okay, then the next step is you have to inspect the face. If there is any central cyanosis present, it marks the hypoxia. If conjunctiva is pallor, then it shows the anemia. You will check the mouth for angular stomitis and central cyanosis. This was the fourth step. Then the fifth step is you have to inspect the chest closely. You have to see the chest wall deformities, that what type of chest it is. Then you have to check for any scars. If central chest, commonly sternotomy or thoracotomy is done, so you will check for dead scars. Then through clavicular, you have to check for the pacemakers if there is any. And at axillary chest drain is done, and its arms left and right lateral thoracotomy is done. These are the common surgeries that are done through the chest, so you have to look for all these. At the central chest, sternotomy or thoracotomy. At axillary line, chest drain is done. At clavicular pacemakers are done, and at arms lateral thoracotomy is done. So you have to inspect the closed chest for these things. Okay, then you have to palpate. After inspection, the next step is palpation. So you have to palpate. First of all, assess the tracheal position. You have to palpate the trachea, that is, assess cricosternal distance, normal 3 to 4 fingers, and palpate apex beat, fifth intercostal space, and midclavicular line. So, in the respiration, first you have to palpate the trachea, that whether it is in the center or is deviated. Then you have to palpate the apex beat, which is present at the fifth intercostal space, midclavicular line. Then you have to assess the chest expansions. Ask the patient to breathe in and out, and reduced chest expansion is present in lung collapse and pneumonia. So you have to find the chest expansions, and from that you can detect that whether lung abnormality is present or not. So first of all, put your hand on the patient's chest and then ask the patient to breathe in and out. And if the expansion is reduced, then it means that there is any abnormality present, which may be lung collapse or pneumonia. Okay. Then percuss the lung fields, that is, resonant percussion is normal. These are the lung fields. These are the positions that I have marked in this diagram. This is position 1, 2, 3, 4, 5 and 6. You have to percuss on these lung fields if there is any resonant percussion present or not. Then auscultate the lung fields. After inspection, we have done the palpation. After the palpation, we have done the percussion, and then after the percussion, we have to auscultate the lung fields. So ask the patient to breathe in and out. Vesicular breathing is the normal breathing. Okay, while auscultating the patient, these positions are used. These are the positions. And you have to ask the patient that breathe in and out. Then the vesicular breathing is the normal breathing, in which the inspiration is increased and the expiration is decreased. So this is the vesicular breathing. Okay, the inspiratory stridor occur in upper airway obstruction. If wheeze is present on the auscultation, it is present in asthma and COPD. If coarse cricles are present on the auscultation, then it is present in the pneumonia and pulmonary edema. If fine cricles are present, then it occurs in pulmonary edema and fibrosis. So this, by auscultation, we can find the different respiratory abnormalities. We have to auscultate the lung fields and ask the patient to breathe in and out. Vesicular breathing is the normal breathing. Inspiratory stridor is present in upper way obstructions. Wheeze is present in asthma and COPD. Coarse cricles are present in pneumonia and pulmonary edema. Fine cricles are present in pulmonary fibrosis. After auscultating, you have to assess the vocal resonance. That is, tactile vocal fremitus is an alternative test. Increase vocal resonance is present in consolidation, lobar collapse and tumor, and decreased local resonance is present in pleural effusion. Okay, you have to assess for the vocal resonance. Tactile vocal fremitus is the alternative test, and if the vocal resonance is increased, it means that there is consolidation and lobar collapse and tumor. If the local resonance is decreased, then it means that there is pleural effusion. Then palpate the lymph nodes. Okay, now we will inspect the posterior chest wall. And first of all, we have to assess the posterior chest wall expansion. That is, ask the patient to breathe in and out. Unilateral reduction is expansion is present in pneumonia and lung collapse. Then percuss the posterior chest wall. There are the types which are resonant. The resonant is normal. If the dull sound is present, it means that consolidation or collapse is present due to fluid. If it is stony dull, then pleural effusion is present. And if it is hyperresonant, then pneumothorax is present, that is air. So, on the percussion, we will find the following things. That is, if it is resonant and it is normal. If it is dull, then consolidation or collapse is present. If it is stony dull, then pleural effusion is present. If hyperresonant, then pneumothorax is present. After the percussion, we will auscultate the patient. These are the positions on which the percussion and auscultation is done. These are the 1, 2, 3, 4, 5, 6, and 7, 8 positions. So, the on auscultation, the vesicular breathing is the normal breathing. If the inspiratory stridor is present, then it is upper airway obstruction. If the wheeze is present, then it is asthma or COPD. If coarse crackles are present, then it is pneumonia or pulmonary edema. If fine crackles are present, then it is pulmonary fibrosis. Okay, so we have performed the percussion and auscultation. Then we will assess the vocal resonance. That is, if the vocal resonance is increased in consolidation or lobar collapse or tumor is present. If the vocal resonance is decreased, then pleural effusion is present. Then we will assess for the sacral edema, and then we will assess for the pedal edema which occurs in the right ventricular failure, and then we will assess for the DVT. So these were the steps in the inspection of the patient. Then we will thank the patient and cover the patient, and we will wash our hands. So let's discuss in general that what we have done in the respiratory examination. First of all, introduce yourself, explain the procedure, take the consent, and expose the patient. Then the next step is you have to do the general inspection. On general inspection, okay, you have to do the general inspection. On general inspection, inspect from the end of the body and find if there is any treatment present around the bed. If there is any cyanosis, shortness of breath, cough, wheeze, stridor or cachexy present in the patient. Then inspect the hand specifically. Note any peripheral cyanosis, bruising or thinning of the skin, tar staining, then finger clubbing. Then assess and compare the temperature of the both hands, and assess for fine tremors, assess for hysteresis, then palpate the radial pulse and assess the respiratory rate. After this, you have to do the you have to assess the jugular venous pressure, that is with patient at 45-degree angle, then located between the two heads of sternum. This is the JVP, and it is located between the head of the two heads of the sternocleidomastoid. Okay, then you have to inspect the face, that is for central cyanosis, for conjunctival pallor, and for the mouth for angular stomatitis and central cyanosis. Then you have to inspect the chest closely. You have to check for the chest wall deformities, the scars. Then the central chest, in the central chest, sternotomy or thoracotomy may present. In the clavicular space, pacemakers may present. In the mid axillary region, chest drains are done, and at the arms, lateral thoracotomy is done. Then you have to palpate the patient after inspection. First of all, assess the tracheal position, whether it is in midline or at the side region. That assess the cricosternal distance, that at normal is 3 to 4 fingers. Then palpate the apex beat, fifth intercostal space, mid clavicular line. Then assess the chest expansions, that is reduced chest expansion is present in lung collapse and pneumonia. Ask the patient to breathe in and out. So you can find the chest inspection. Then percuss the lung fields. Resonance percussion is normal. Okay. Then you have to auscultate the lung fields. Ask the patient to breathe in and out. Vesicular breathing is the normal breathing. If inspiratory stridor is present, then upper airway obstruction. If wheeze is present, then asthma or COPD. If coarse crackles are present, then pneumonia and pulmonary edema is present. If fine crackles are present, then pulmonary or fibrosis is the cause. Then you have to assess the vocal resonance. Tactile vocal firmness is an alternative test. Increased vocal resonance in consolidation, lobar collapse and tumor. Decreased local resonance is occur in pleural effusion. Then you have to palpate the lymph nodes. Lymphadenopathy causes are infection, malignancy and sarcoidosis. Then you have to inspect the posterior chest wall, assess the posterior chest expansion, ask the patient to breathe in and out. Then unilateral reduced expansion, that is pneumonia or lung collapse. Then percuss the posterior chest wall. The types are percuss the posterior chest wall. Okay, if it is resonant, then it is normal. If it is dull, then consolidation or collapse is present. If it is tonical, then pleural effusion is present. If hyperresonant, then pneumothorax is present. Then you have to auscultate the patient. The vesicular breathing is the normal breathing. If inspiratory stridor, then upper airway obstruction. If wheeze, then asthma or COPD. If coarse crackles are present, then pneumonia or pulmonary edema. If fine crackles are present, then pulmonary fibrosis. Okay, then assess for the vocal resonance. Increased consolidation is present in lobar collapse and tumor. Decreased in pleural effusion. Okay, if decreased pleural effusion is present, then if the decreased vocal resonance is present, then it is pleural effusion. Then assess for the sacral edema, then assess for the pedal edema, and then assess for the DVT. So then ask the patient, then thanks the patient and cover the patient and wash your hands. So this was the basic method for the respiratory examination. Now how we will represent? It will represent it as, in summary, I performed respiratory examination on Dash of Dumre years old, and he has no peripheral cyanosis or respiratory diseases. His pulse was regular and respiratory rate was normal, and Dash has normal and symmetrical percussion node on front and back of the chest. In auscultation, he has normal vesicular breathing with no added sounds. This was normal respiratory examination. To complete the examination, I will do the O2 saturation test and sputum sample. So these are the points which we should remember. The vesicular breathing and the bronchial breathing. The vesicular breathing is low pitched, inspiratory is increased, and there is no pause in inspiration and expiration, and it is normal breathing. The bronchial breathing is harsh, the expiratory is increased as compared to inspiratory, and there is a pause present, and it is abnormal breathing. Now the another thing that we should remember is that reduced chest expansion occur in lung collapse and pneumonia. Inspiratory stridor occur in upper airway obstruction. Wheeze occur in asthma and COPD. Coarse crackles are present in pneumonia and pulmonary edema. Fine crackles are present in pulmonary fibrosis. Increased vocal resonance is present in consolidation, lobar collapse and tumor. And decreased vocal resonance is present in pleural effusion. Reduced expansion is present in pneumonia, lung collapse. So here we have covered the respiratory examination. In the next section, we will be discussing the abdominal examination. Thank you.